Welcome to the second episode of video course AI for Healthcare Experts. If you didn't watch first episode, I highly recommend to do it because we will refer to some concepts from first episode here, and it's much better if you will understand it correctly. This time we will talk about metrics, incredibly important thing in the whole machine learning field. So let's start. And let's start with practical example. I think it's much better to than just theory. So we have a classical task. Uh, we have 400,000 chronic disease patients. We know a lot of information about them because they assume some of them were wearables. They are most of them old, and we know a lot of information about them in electronic health record system. We have some their analysis, diagnosis, and we know history for let's say 5 to 10 years of other patient and this patient also. So it's data rich environment. We can do a lot with it, but we don't have time and resources for this. So assume in the best case we can review only 10,000 patients, let's say in a month, but in reality it can be like in a year. And we can review them to provide some support to prevent hospitalization, to provide some additional care. And the problem, we don't know whom to address. So in most of the cases, these calls or visits quite sporadical and or based on some schedule, and they are not data driven, and they lead to a lot of unnecessary visits. So a lot of workload excessive on clinical staff, and preventable hospitalization when the visit was done to or care was not provided to somebody who needed this at the moment, but we just didn't know about this. And we want to build some machine learning model that helps to highlight whom we should provide support now or tomorrow. And such kind of models, they're used very widely in all fields, like in financial sector, it detects fraud transactions, or this is something that provides you some additional recommendation when you buy like groceries, or it detects additional potential damage in cars or some industries, for some machinery in steel industry or in construction. So these algorithms with us around us for I think 10 to 15 years already, and they used everywhere widely, except healthcare. And that's the reason why we do this now, listen in this podcast video. Uh, so classical solution for this problem by machine learning algorithm. We take some historical data, for example, history and information about hospitalized patients in the last 5 years, hospitalized and not hospitalized patients for 5 years. We know their parameters, we know their outcomes, and based on some numbers, as we talked last time, that describe patient condition. These numbers in machine learning, they are called features. So something that describe patient, like for example, age, respiratory rate, average respiratory rate during sleep, during duration of non-invasive ventilation during sleep, or let's say some behavior parameters like sport exercise or smoking, or some results of some analysis. So everything, they're called features, and they described by numbers. And based on this, we can build model, a machine learning model that can predict hospitalization. Like, because we know history for 5 years for, let's say, 100,000 people that were or were not hospitalized. We know everything about them, and our goal is just to find out necessary weight. So we discussed it last time. So again, episode 1. And let's say now assume we build this model. Important off topic, but it's really important. And this is also one of the reasons why I do this video course. because features must be provided from experts in the field, so from healthcare experts, because even if data scientists will have all the data, they unlikely will be able to build model that accurate enough and useful enough. So in a lot of cases, it will be something mathematically right, correct, accurate, but completely unapplicable, or worse, it can be wrong on some new data. So this is very important to consider, that features should be provided by experts. And weights and model training, what does it mean? It means that how these features will be transformed to numbers. Should we make some regularization, standardization? Should we make augmentation of data? How should we choose a model to train? How should we train it? All of this is better done by data scientists usually. So it's good if we can collaborate to build good model, like data scientist and industry expert. So again, in other fields, it usually happens this way. And assume we had nice collaboration, we worked hard, worked a lot, we built a model that works well, but how to understand how well is it well enough, and can we use it or not, and what to expect from this. uh, to understand this, we should just calculate what kind of errors and how often model does. So we have two types of errors in general, and it's not only for machine learning, it's relevant to any diagnosis, any analysis. So it's always false alarms. In intensive care, 80%, based on studies, like 80 to 60 to 80% of alarms are false, and the same can be in machine learning. So false alarm when a machine learning model said the patient will be hospitalized, and he was not in reality. So model said patient will be hospitalized, but he's fine. And uh, Another type of errors, it's called type 2, false negative, when model didn't say that um, patient will be hospitalized. Model said that patient will be okay, will be fine, and patient was hospitalized in reality. So this is false negative. Two types of errors, nothing specific for machine learning. It also exists in all other things like analysis and diagnosis in healthcare. So nothing new, but it's important to understand that it's also relevant to machine learning. Usually it presented in the form of confusion matrix. So we have uh, predicted results, like hospitalization or not, and reality, actual result, hospitalization or not. And when it is both reality and prediction is hospitalization, it's true positive. When model said that this is no hospitalization, but in reality it was, this is false negative, it is missed case. And in reality there was no hospitalization, model said that it will be, it's false positive, false alarm. And no hospitalization for both cases, it's true negative. uh, Pretty simple, but this is core topic to use wisely machine learning models. So now let's review how it works again with some model, real model, and some real metrics. We have some uh, models. So this is patient, blue are healthy, red are sick. So there are no, currently there is no like age or blood pressure as last time. We just have all the parameters that it can be like 200 different parameters that describe patients, but we visualize them in a way that healthy patient mostly on the left side, and uh, sick patient mostly that were hospitalized on the right side. And there are always some overlap that makes things more difficult. And so right now, this is confusion matrix. So model predicts that it will be sick, so that it is red. So everything that right from this line will be sick. and everything to the left, it will be healthy. And actually sick, like true positive 74, and they are predict sick. This is false alarm, missed cases, and true negative 262. And that's what we have. Also, based on this true positive, true negative, false negative metrics, usually used some other. It's like sensitivity, how many, so it's like true positive divided by how many we caught sick, how many we detected, divided by total amount of sick patients. So true positive divided by true positive plus who we did not detect. So it means that red dots from here divided by all amount of red dots. So that's it's called sensitivity. So how many out of all sick, how many of them we detected? Specificity is opposite thing. So correct healthy. So how many blue dots on the left? So how many we said that will be healthy, will not be hospitalized, divided by total amount of healthy. So blue that we correctly detected divided by total amount of blue patients, blue dots. So this is how specifically our model, so how often it makes a mistake. And obviously the higher the better. And precision, it's a little bit different thing. It's similar to specificity, but it's true positive. So how many red we detected divided by total predicted positive. So true positive plus false positive. It also describes amount of false alarms. So here it means that on like 1 out of 3 detected thing will be false alarm here. So we said that model predicted like 74 true positive and only out of 102, and 38 were false positive. So it means that 33% of the cases, even 34% of the cases, there will be mistake. So this is not like very good performance. So it means that a lot of false alarms. Okay, let's fix it. We can change the threshold. So as you remember, model provides not the yes or no, it always provides some percentage. So as you remember, last time we evaluated risk, and we said that, okay, if risk more than 5, then it will be heart attack. Here it's something similar, but we can say that if risk is more than 6, then it's heart attack. So we increase a little bit threshold, so we move it to the right, and we reduced our sensitivity, but we improved our precision. So our model now more accurate. It detects less red dots, but if it said that patient will be sick, more likely it's right. So we build more trust to the model. So it's now mistakes only 1 in 4. And if we switch it a little bit even far here, now it mistake 1 in 10. And for example, like here, it will be like 1 in 5, but we missed more than a half of all cases. So it's always trade-off. And next time, it will be very interesting, I think, an important topic to discuss when should we use high model with high specificity, when should we use model with high sensitivity, and how to define better thresholds. It's not obvious, and if you make it wise and correctly, it can really be the difference in usage. And this something that usually I see from a lot of papers and a lot of talks with those who try to implement models. this thing is very often missed. So I think next time will be very interesting to discuss it. One more thing, if you read any machine learning papers, or you read about algorithm that detects some disease or make some prognosis, so you always will hear a term ROC curve. So it means ROC curve, and this is a yellow line, and this line, it means we flip a coin, so it always like 50% accuracy. So that we take the any patient, we flip the coin, and it's always 50% that will patient be sick or healthy. And yellow line, it's how better our model is. So the closer this yellow curve to the to the 1, the better. So if it will be from 0 to 1 and 9 to 1, it means that it's absolutely correct always. So let's say we have high precision diagnostic, different distribution. So you see that here we detected like absolutely correct everything. So we always have 100% sensitivity, specificity, precision, so no mistakes. And our ROC curve like just square, so it's not a curve, it's just square, so no any mistakes. And it's usually we don't need machine learning for this in this case. So standard screening, it's always will be something, so it's you cannot be absolutely correct. And what does it mean? So if we move to the right, so we make model more accurate but less sensitive. This means that current thresholds goes here. So it means that we have not many false positives, so specificity is very high, but sensitivity is very low. And this curve is curve of trade-off. So we want to increase sensitivity, and we have to reduce our specificity. It's always, so here we achieved 100% sensitivity, but our specificity is very bad. So we almost always have false alarm. So like 60%, 70% of our results are false, but we detected all of them. This what we can see in ROC curve. So also a pretty useful tool, but keep in mind that it's some aggregated thing. For me personally, much more convenient to see confusion matrix. It's more understandable, or this sensitivity, specificity, and precision. One more thing that's interesting to review, it's rare disease. Rare disease, it's imbalanced data set, so we have much less sick patients, and they are very noisy, so sick patients look like healthy. And you see the ROC curve much closer to the flipping coin, and this means that maybe our model is wrong, so we need to add additional features, so we should uptrain it, or our data is wrong. So these things are usually unapplicable. So it's when ROC curve looks this way, it's unlikely anybody will use it. But it's important to understand like the real performance, and that's how we can also move threshold, for example, to make a little bit more accurate model like sensitivity, specificity, and this is important. Let's say reshuffle database, so it's we make different distribution of patients, but we see that it's still not perfect. So here it's a little bit better model performs. So maybe here it will be, yeah, it not so bad, but again, a lot of like false alarms. It's awful, of course. So I wouldn't use this model for in real practice. So we need something else, and we will discuss how we can do it in next videos. So I hope that wasn't difficult. I hope now it's much clear how to evaluate model, how to read things that we have like 100% sensitivity, and because you see like specificity can be very high but precision very low, so you now understand better where to look to understand does this model fit your needs. And see you next time.